Hadda sir, who is a professor in the Department of Pulmonary Critical Care and Sleep Medicine from the All India Institute, New Delhi. Sir will be talking on NSIP, organizing pneumonia, and the overlap. Over to you, sir.
Thank you, Irfan, and thank you, CMCU Vellore, for inviting me here. So I think in ILDs, especially IIPs, there are two major diagnosis. One is IPF, which has already been covered by Dr. Uma. And if we see what is the next one, that is the NSIP. That is the second most common IPF in IIPs. Even in some studies, it has been considered as the second most common cause of ILDs also. But with more and more understanding regarding ILDs, the more recent studies say that NSIP is not very common. So as I told, NSIP is the second most common IIPs, idiopathic interstitial pneumonias. It can be two types, maybe fibrotic or cellular. Depending on CT scan or histopathology, we can differentiate it. And age group is more or less same as IPF, but it is slightly younger. Although in a given patient, it will be very difficult to say whether this patient is having IPF or NSIP. Prevalence is a little bit higher in women. Reason being because most of the NSIPs are secondary, and CTD is the most common cause of NSIP pattern on CT scan or histopathology. So that may be reason why NSIP is more commonly seen in women. And although if we see overall idiopathic NSIP, the prevalence is same in both genders. Smoking has no relation to do with NSIP. So when we approach any ILD, so these are the simple steps. I have made these kind of steps, but I think these are the steps how we approach any pattern. So first we identify and confirm the pattern, then we evaluate for the cause, then we do MDD to make a final diagnosis, and then before starting therapy, we need to assess the severity, associated comorbidities, and then we make final treatment plan. So this is a case of 66-year-old lady who is homemaker. There is no history of smoking. She already had a hypothyroidism for last 10 years. For that, she was taking replacement. She came to us with slowly progressive shortness of breath, which is now grade 3. So duration of illness is almost 10 years. Dry cough. Intermittently, she was saying feeling of fever, but it was never documented. And on examination, findings of ILD or DPLD were there. And on room air, saturation was 93. So this is, I think, minimum kind of a information we get from any patient. And this was the CT scan. So I will not tell the findings, but this is how a patient come to us. If we go again to all the pattern in the CT scan, then definitely somebody will say there is no definite UIP pattern on this. And also alternative pathology especially, there is no finding suggestive of typical nodules or GGOs or cysts, which are typically absent. So at least we can say there is no typical finding of HP, no typical finding of any cystic ILD, or no typical finding of at least classical kind of sarcoidosis. So this much we can say with this CT scan. And if we see the coronal sections, again, if you see the patchy involvement, but again, apicobasal gradient is there. There are reticulations, but there are no honeycombing. Somewhere there are little bit of broncholectasis also there. And if you see little bit here, this involvement is more along the bronchovascular involvement. So it is peri-bronchovascular kind of involvement is more there. So if we see the mediastinal window, as I was telling, that mediastinal window is as important as parenchymal window to say that whether it's single compartment disease or a multi-compartment disease. So here there is no pleural involvement, no pleural effusion, no pericardial effusion, no lymph nodes. And one more important thing is always look for pulmonary artery to see is there any radiological evidence of pH. Sometimes CT scan parenchyma is very limited disease, but pulmonary artery is too big. So that also gives some clue that pH is out of proportion to the lung involvement. So it may be something else than idiopathic ILDs. For example, in scleroderma, the pH can be out of proportion. So that can also be a clue. So these are the findings of NSIP. I think in the morning, very beautifully described by one of the speakers that what are the typical findings of NSIP. But again, all the ILD will manifest in the same way: reticular opacity, irregular linear opacities. There will be thickening of bronchovascular bundle. Traction bronchitis will be there. There will be loss of lung volume because it's a fibrotic disease. In advanced stage, you will see traction bronchitis. There can be consolidation, microcyst, honeycombing is less common. Usually, if there is a classical kind of honeycombing, then chances of NSIP will be less. If we see the pattern, those were the abnormalities, then these are the pattern, that it will tend to be subpleural, symmetrical with apicobasal gradient. If it is predominantly upper lobe involvement, then chances of NSIP are less. So if predominantly apical lobes are involvement, then we will not say that on CT scan at least is a NSIP pattern. It can be cellular when there is lots of GGOs, and usually this subpleural sparing is considered as a feature, but is not very common. But if it is there, it's considered very, very specific. So these are the classical examples. If you see the CT scan, all the CT scans, you see there is a subpleural kind of a lesion which is showing reticulation type, and immediate subpleural is totally spared, and there is no traction bronchitis kind of thing. So this look like is predominantly cellular kind of a NSIP. So here again, if you see there is lots of GGOs, but there is a bronchitis also. If you see there is dilatation of this whole bronchitis here, so there is traction bronchitis is there. So here is a cellular as well as fibrotic NSIP. Again, another example where you can see there is a GGOs, lots of GGOs, and but there is a bronchitis also, there is traction bronchitis. Here also you can see GGOs and this. So see, it again make a case that is say at least CT scan is suggestive of NSIP pattern. What about OP pattern? So OP is nothing. OP is just like consolidation, but there is a classical kind of pattern. There will be bilateral, symmetrical, peripheral. These are 2-3 keywords which are commonly described when we are saying that is a organizing pneumonia. So if you have multiple or serial kind of a radiology, you will see their fleeting shadows. This is a classically happening with OP, that some area will be involved, after some time that will disappear, and another area will be involved. So that is a OP pattern. So this is what. So how to differentiate NSIP and UIP? This is very simplistic way, but as Dr. Uma was telling, in many cases we are stuck so hard, it's very, very difficult to tell whether it is NSIP or UIP, like we were discussing. Probably UIP, if you see all the features, they are fitting into NSIP. So in some cases it can be very, very difficult, but if you are finding widely spread honeycombing, subpleural distribution, apicobasal gradient, then there is more chance it is UIP, and vice versa. If there is relatively peribronchial distribution, more GGOs, subpleural sparing, then it is more suggestive for NSIP. The second thing is, we on CT scan we have reached to an extent that it look like NSIP pattern, but is that enough? No. This is the data from our network which have shown that what all the conditions which can present as NSIP pattern on CT scan. So you can see idiopathic NSIP constituting the largest number, approximately 48%, next the CTD ILD. It is little different as described in the literature. There can be multiple explanations for this. We are not going to that, but what message I want to give here is NSIP has multiple regions and it can present in many diseases. NSIP can be seen in CTDs, it can be seen in hypersensitive pneumonitis, it can be seen in many patients. When you proceed further, NSIP turn out to be IPF also when we do biopsy. So it can be seen in sarcoidosis also, although it's less common, but atypical presentation of sarcoidosis can in the form of NSIP. So once, because we know that there are multiple causes, so we need to identify the causes. So as I told, the CTD is the commonest cause in this. Then hypersensitive pneumonitis, sarcoidosis. It can be drugs, for example, amiodarone, methotrexate, anti-cancer drugs, which are very common. Infections, very, very common, and HIV is a one infection where it can present. If some patient is not known case of HIV, then again we can misdiagnose that. Then IPF, it is a newer terminology, is a type of ILD, although it's a new entity. In future we will come to know, but IPF or IPF, NSIP is the pattern which is described in CT scan or histopathology. Some rare DPLDs, for example, IG4 related disease, familial ILD, graft versus host disease, they can also manifest as NSIP pattern on CT scan. And once we have ruled out all this, then comes the idiopathic one. So to reach that, we need a great evaluation, which will be in the form of clinical laboratory in bronchoscopic or lung biopsy. So clinical evaluation, I think symptoms in all ILD will be same. So I am not bothered about that. I am more concerned about extrapulmonary symptoms and symptoms which are indicative of connective tissue disease. They are very, very important. So symptoms related to joints, skin, eyes, muscles, we need to focus on that. Then Sika symptoms. These are very important to make a diagnosis of secondary causes of NSIP. Then signs, again, I am not concerned about the findings of ILD itself, but I am more concerned or more focused on finding any telltale signs of connective tissue diseases. For example, skin tightening. Sometimes the changes may be so subtle. You will see the tip of fingers, there will be some pitting kind of ulcers which are, if you don't see diligently, you will miss. Sometimes the fingers will be cracked in a patient who is just an office worker. So if we can pick those up, then probably there will be more chances of picking a subtle kind of connective tissue disease. Then additional history regarding detailed drug intakes. So these include allopathic as well as the alternative medicines. So we need to take a detailed history, and many times there are newer and newer drugs are coming, especially biologicals, and other drugs also we don't know whether this can be responsible for lung toxicity or not. For that there is a site pneumotox.com. We can go there and we can put the drug and find out what are the pneumotoxicity of that particular drug. Then comes the occupation. That is very, very important, and many times we take this history very superficial. We will ask, what is your occupation? He will say, I am an office worker. We stop there. No, we cannot stop there. He may be involved in some kind of leisure activity, for example, gardening, or he may be frequent traveler, or there may be other hobbies which can put that patient on exposure related disease. So occupational history is very, very important. Not only current, the previous occupations also. So we need to take the detailed history. Family history, especially the young patient or patient who are having HP, this is very, very important. And sometimes this hypersensitive pneumonitis is very difficult to remember all the questions. If you can prepare a questionnaire and you can keep on asking, then that can also be helpful. Although guidelines say that use of questionnaire is not adding anything, but probably that is in expert ILD centers. If you are starting new, there is no harm in making a questionnaire and asking questions based on that questionnaire. And also this question will be varying from region to region. The activities which lead to ILD in Western countries may not be true in our setting. Then comes the examination. Again, I would like to see again regarding this connective tissue diseases, history as well as examination. So I have written few things, but there are many things other than this. For example, exposure to pets. So many times we just ask pigeons, but the pigeon are not only birds. There are other birds also which can lead to development of hypersensitive pneumonitis, which can manifest as NSIP pattern on CT scan. Similarly, these are few symptoms which can indicate connective tissue disease. So we should, again, we can keep a list and keep on asking those questions. If on that symptoms there is no cause, then we can start thinking it may be idiopathic one, but we also require some blood testing. So there are serological testing is very, very important. In all the patients of ILD, at least these three need to be done. These are the minimum requirement in all patients. But when you are working up a patient with NSIP, you will require more detailed evaluation, which can include ENA profile or sometime myositis panel also. So unless we do all these tests, and in some patient hypersensitivity panel also. So unless we do this exhaustive workup, we cannot say that the given patient is having idiopathic NSIP. If we will not do a detailed workup, then there are chances that NSIP was because of some secondary cause which we have missed. So in the given patient, when we did this routine investigation, including the hemogram, liver function, kidney function, INR were normal. All this initial serology in the form of rheumatoid factor, ANA, anti-CCP were negative. Extended nuclear antibodies panel was also done, which was also negative. Hypersensitivity panel, we asked the patient, but the lady was not affording, and we also thought probably this is not a right setting, so we deferred it. Spirometry done, which values are shown here. The FVC was 53%, FE1 57, the ratio was 85%, and there was severe impairment in DLCO. 6-minute walk test also was impaired, and during 6-minute walk, she desaturated significantly. So then we took this patient to MDD and we correlated all, but we were unable to find any cause. So still, before making it idiopathic, we thought that we should do little bit more. So we considered BAL and probably lung biopsy. So what are the role of BAL and lung biopsy in patients with NSIP as compared to IPF, where everybody was agreeing that if CT scan is classical of UIP or definite UIP or probably UIP, you may not require lung biopsy or bronchoscopic BAL. But in case of NSIP, it is said that in many patients, before labeling it idiopathic, we will need a sampling. So if patient is fit, we will do BAL. BAL may not be diagnostic of NSIP, but it will help in ruling out secondary causes, especially infections. Sometimes the DLC or differential count can help in making diagnosis. For example, there is lots of lymphocytosis. It can indicate that patient may have hypersensitive pneumonitis in a correct setting. And also we should remember that if in some cases it can be diagnostic malignancy also. So this is a slide showing where BAL can be helpful. For example, NSIP OP pattern is there or OP pattern is there, and there is eosinophilia more than 25%. So we can easily make a diagnosis of eosinophilic lung disease. Lymphocytosis can be seen in these diseases, hypersensitive pneumonitis, sarcoidosis, or cellular NSIP. In few diseases, for example, CD1A positive is there, that is diagnostic of pulmonary Langerhans cytosis. If milky BAL is there, that is almost diagnostic of pulmonary alveolar proteinosis. So BAL, especially NSIP setting, is very useful test. Then comes the lung biopsy. So still it is considered the gold standard for histopathological diagnosis, not for ILD diagnosis. For ILD diagnosis, MDD is the gold standard, but histopathological pattern, the lung biopsy is gold standard, and it is especially required in situation where clinical evaluation, including all the laboratory tests, serology, your hypersensitivity evaluation, all are negative. In those cases, we should strongly consider lung biopsy if patient is fit. So whether we want bronchoscopic, TBLB, cryo-TBLB or surgical, that will depend on your setting where you are working and what are the facilities which are there. So, but as in all other ILDs, this should be decided after MDD. So overall, the TBLB as far as the diagnostic yield is considered in NSIP is not very good. Only probably if it is atypical sarcoidosis or in some cases of HP, you can get a diagnosis. Otherwise, most of the time, it is not a good modality for lung biopsy. Cryo-TBLB or VATS. These are the two modalities which are useful, because nowadays all the pulmonologists are doing cryo-TBLB. Then it can be a good alternative for VATS or surgical lung biopsy. So I am not telling this the yield, but if you are doing a cryo-TBLB, it has a reasonable yield in tune of around 80%. So in this case, we performed the BAL, and reports is showing here. The alveolar macrophage is 60%, neutrophil 30%, and lymphocyte were 10%. Infective workup was negative, and we performed cryo-TBLB, and the findings were suggestive of non-specific interstitial pneumonitis. They could not find any granuloma or organic pneumonia pattern or giant cells. So after MDD, we label this patient as a idiopathic NSIP. So this is how we reach a diagnosis of NSIP in a given patient. So next step will be, before deciding the therapy, we need to assess the severity as well as how many comorbidities, or is there any comorbidity there in the patient or not, because that will decide the treatment. So severity can be assessed based on the CT scan, spirometry, or DLCO or 6-minute walk test. We do it, and in this patient, as we told, comorbidity in the form of liver function, kidney function were normal. Spirometry we have already discussed. 6-minute walk test we already discussed. CT scan you can see. There is no need to calculate the numbers many times out of the research setting. You just can eyeball and you can say that there is significant involvement. So this is important, especially if NSIP is there in CTD associated ILDs, where in many times we just observe the patient instead of starting therapy. So if it is less than 10%, less than 20%, less than 30%, so lesser the involvement, we will go more toward observation as compared to start of treatment. But in this case, there is no, that is not the option, because there is extensive involvement of the lung. So this patient definitely will require treatment. And it will also depend on the cause, whether it is the NSIP is secondary to some cause, for example, exposure, drug, or connected to tissue disease. So if that is there, then we will address the cause, disease severity as well as progression. Sometimes at initially we are not starting treatment, but if patient is progressing, then we start the treatment. If NSIP symptoms are very less, or the PFT or spirometry is preserved, in those cases we can just observe and we can keep on following these patients every 3 to 6 monthly. And once there is progression, we start treatment. Once we have decided that this patient needs treatment, for NSIP there is no treatment as such, there is no guidelines. All the treatment, they are based on experience from CTD associated NSIP. So usually we have the option of glucocorticoids or steroids and immunosuppressive agents. So usually when you are starting treatment, so 0.5 milligram per kg body weight is what we start, and there are different regimen, and there is one study which have reported that probably if we start little bit higher dose at the induction, then response rate is a little higher. So maybe 0.5 to 0.75 milligram per kg body weight may be a adequate kind of dose, and we taper that dose over next 6 to 9 months. There is another study which say that probably 9 months is little better as compared to 6 months. Then comes to the immunosuppressives, MMF and azathioprine. These are the most commonly used. Methotrexate is option, but considering the pulmotoxicity of this drug, most of the time we avoid it. And cyclophosphamide rituximab, in some scenario we use. MMF dose, you may be knowing that we can give up to 3 grams per day. We start with low dose and then probably slowly we reach. This is how azathioprine is usually started. With low dose we can increase it, and target is usually 1.5 to 2 milligram per kg per day. Cyclophosphamide, there are few data in retrospective kind of studies which have shown that it has some effect, and again the experiences are from connective tissue disease related ILDs. Rituximab, again the NSIP in CTDs, it is given once patient is kind of not showing response to your conventional immunosuppressives. So we give this, but results are not so exciting. Many patients are coming back to our ward with the infection, and in some cases it can lead to worsening or exacerbation also. So we need to remember that. There are other options, for example cyclosporine or tacrolimus. These are the alternatives if patient is not tolerating the first line MMF or azathioprine drugs. Coming to antifibrotics, again principles are, I think directly NSIP there is less data, but most of this data is from the IPF or fibrotic ILDs studies. For example, in inbuilt study where they have studied fibrotic ILDs, where there are few patients who are having NSIP pattern with fibrosis. So we can use that, and at our center, wherever there is a fibrotic form of NSIP, we usually use the antifibrotics. Dose is same as prescribed for IPF. So we can use that. Other therapies, acute exacerbation, same as IPF or IPF, and sportive is same. If patient is requiring oxygen, we give that. Pulmonary rehabilitation, vaccination, lung transplant, this should be offered to everyone. I think pulmonary rehabilitation is one which is highly neglected. If you can make it an integral part of your ILD clinic, that makes a huge difference in the patient quality of life. Vaccination, one should not forget that. And lung transplant, obviously, in patient with IPF, directly once we have made a diagnosis, we usually at least start talking about the lung transplant to the patient. In NSIP, once you think that patient is progressing, then you start talking about that. As far as success of this lung transplant is considered, there is no difference in IPF versus NSIP. So take home message from this talk, which we discussed in last 20-25 minutes, is NSIP is the second most common form of IIPs. And most of the time, NSIP is secondary, and the common cause is connective tissue disease, sometimes drugs, infections, sometimes malignancy also. In many cases, NSIP, OP commonly exist. So the etiology, more or less, workup is same. Idiopathic NSIP, if you are making diagnosis, it need a lung biopsy, because many patients of idiopathic NSIP turn out to be IPF, and UIP and final diagnosis revised. Treatment options include immunosuppressive or antifibrotic, as we discussed. So thank you everyone. If there are any question or comment, I will be happy to respond.
Thank you, sir. We have time for a question or two. Okay, so if there are no questions, then I think we'll close the session.
I just have a
Yes, sir.
question about the role of antifibrotics. Often the approach is similar to what we discussed at the end of Dr. Uma's talk. If we are approaching it from an idiopathic perspective, where a fibrotic NSIP is going to be similar to probable UIP, and there is no etiology, it falls into the basket of IPF as a diagnosis. But if we are looking at it from a non-IPF clinical scenario, and we are looking at fibrotic NSIP, we need to give the benefit of immunosuppression to the patient unless there's proof of progression of fibrosis, which will then categorize it into progressive pulmonary fibrosis. Because that area is a bit gray, and if you're not careful, there will be a lot of patients who will be on lifelong antifibrotics when they may not actually need it at that point in time. So,
yeah, I think that is a very good point. So if you can divide patient into two parts, IPF, non-IPF, and if patient is coming first time, then if IPF is ruled out with the confidence, then if you want to treat, always start with immunosuppressives. Because in all the diseases, be it HP, be it connective tissue disease, the underlying mechanism is inflammation. So unless we stop that, disease will not stop. So it will keep on progressing. So that is, I think, very important message. Thank you, everyone.
Now we'll move on to the next talk. I'll now call upon Dr. John Matthew, Head of the Department of Rheumatology, Christian Medical College, Vellore, to chair the session on CTD ILDs.